This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to our podcast on amyloidosis. My co-chair of the session, Dr. Mustafa Ahmed, Director of Interventional and Structural Program at UAB. We have a special guest today is Dr. Jason Guichard, who is the Advanced Heart Failure Specialist, Director of the Heart Failure Program, as well as the Transplant Program at Prisma Health in South Carolina. Gentlemen, welcome to our podcast. Now, some people may ask themselves, why amyloidosis? And we felt like it would be important because amyloidosis is life-threatening and it's underdiagnosed. And it's a disease that is associated with heart failure. As we know, approximately 1 to 2% of the adult population in the United States has heart failure. And the prevalence in patients that are greater than 70 years is actually greater than 10%. It is predicted that by 2030, in the next 10 years, we'll have approximately over 8 million people that suffer from congestive heart failure. Of these, about 50% have heart failure with normal pump function. There are several causes for heart failure with normal pump function, but very little treatment. Amyloidosis is one of those causes, and we have now some treatment for amyloidosis. For this reason, we decided to do this podcast, and we have a specialist in amyloidosis center in South Carolina, Dr. Jason Guichard. Jason, tell us what happens to your body when you have amyloidosis.
Yes, there's kind of 4 common causes of amyloidosis, and particularly cardiac amyloidosis, which is what we're talking about today. And really, it's identifying which of those 4 you may have, and that guides treatment. So really, the 4 types is AL amyloid. This is due to abnormal light chain production from the bone marrow. The second group is what we call TTR amyloid or transthyretin amyloid. This is an abnormal protein that's made in the liver, which then misfolds and aggregates and then deposits in the heart. And the TTR can actually come in 2 forms. One is called wild type, which is normal. And the other type is what we call hereditary, which is a mutant protein that predisposes someone for this particular process. And then the 4th is AA amyloid, which is due to serum amyloid protein A, which is generally due to inflammatory processes. One of the more kind of common ones would be rheumatic fever. This is rarely seen and developed in the industrialized nations. We generally don't see this a whole lot. So the 2 major types of amyloid that's found here in the United States and most industrialized nations is AL amyloid and TTR amyloid. So the first part is actually distinguishing which 2 you may have, and that's the first thing that any physician will do and talk to you about. So there's actually a host of different tests and imaging that can be done to kind of distinguish those 2 types.
So before we get into this, Jason, normally the liver produces this protein, this transthyretin, and I guess in certain people that suffer from congenital or familial amyloidosis, that protein is abnormal when it's made into the liver. But in patients that have secondary amyloidosis or in patients that are in the elderly, the protein is actually made by the liver, comes out normal in the bloodstream, but then something happens, it becomes unstable, and then what happens?
Yeah, that's a great question. So the normal protein becomes unstable, disassociates, and then those, it's normally what we call a tetramer. So 4 little subunits bind together into the normal protein. But in certain cases, we don't exactly sure know why. In some people's bodies, that tetramer dissolves, and these proteins become monomers, so just single units, and then they aggregate to form amyloid fibrils. And those fibrils are then deposited into the heart. So that that's how the wild type or normal transthyretin pathogenic process happens.
They get deposited into the heart as well as other organs.
That's correct. So amyloid is a multi-organ process. The main thing for TTR is the cardiac part or cardiomyopathy, but there's also a huge affinity for nerves as well. So polyneuropathy or other neuropathies are a huge part of TTR amyloid, as well as in some cases AL amyloid. And AL amyloid protein can deposit in the kidneys, in the liver, in the tongue, as well as the heart. So amyloid, we're talking specifically about cardiac amyloid. We're cardiologists. This is a cardiology podcast, but the reality is that these proteins can actually deposit in multiple different organs. And depending on which type, there's a predisposition for the proteins to deposit in various different organs. But yes, this process is a multi-organ issue, which is why multidisciplinary clinics and multidisciplinary groups are incredibly important, both on the hematology side, the neurology side, the orthopedic surgery side. There's a lot of overlap of this disease process amongst various different specialties.
So, Jason, 2 questions. So when I was training initially, and Dr. Bouchard, you'll probably echo this. So, amyloid wasn't this big thing, and now it's one of the hottest topics there is in terms of advancements in cardiology. So, what kind of happened there over the last 10 or 15 years or so? And the next thing is, when people have heart failure, right? Normally that's shortness of breath, maybe swelling, that kind of thing. Well, when someone goes to see a doctor, is there anything special about how those people present when it comes to that, specific heart failure, where you would think, oh my gosh, you've got, amyloid versus other types of heart failure?
Yeah, those are both excellent questions. So we'll answer the first one first. So the main reason why cardiac amyloid and specifically TTR amyloid has become kind of rose in prominence is that now we have medicines to treat it. So before, up until just a year ago, there were no treatments for this disease process. So there was a lot of pragmatic people that believed, if we can't treat it, then why are we looking for it? So I don't necessarily agree with that thinking, but that was largely the thinking amongst physicians, that if you can't treat something, if you can't help something, then why care about it or why try to identify it? But that's no longer the case. So there's been a huge revolution in the cardiac amyloid space as far as medications that we can use to actually treat these patients. As a matter of fact, there's even newer medications in the pipeline. So this has now become a disease process that we can treat. And therefore the awareness and the excitement around this disease process has increased. So the short answer to your question is, why is it rising in prominence now? Is that we can actually treat it, which is exciting, especially for people who have been waiting for these treatments for a long time, seeing these patients kind of dwindle and suffer. We now have actually medications to help improve their quality of life and their mortality. The second question, sorry, what was the second question?
So that's awesome. So when people normally present with heart failure,
that's right.
It's like, shortness of breath, swelling, fatigue, and we've been making that diagnosis commonly. Is there something for, either in terms of from a patient basis or just an examination basis, where you would think, gosh, we really need to rule out amyloid as a cause?
Yeah. So, heart failure, has very general, diagnostic symptoms, shortness of breath, dyspnea on exertion, shortness of breath when you exert yourself, or swelling. So, there's those are very general symptoms. Largely cardiac amyloid, at least in our office, we kind of exclude other common causes of heart failure first, before we go down that route. So treating people with medical therapy for heart failure, whether that is diuretics or otherwise. And if patients still have persistent symptoms, is one thing. So symptoms out of proportion to what you actually see on your evaluation or what you see on the echocardiogram, or some red flags, some clinical red flags, which are well known in the cardiac amyloid world. If these patients kind of meet those red flags or kind of check the box of those red flags and increase their pretest probability for having cardiac amyloid. And those would all be indicators where you would consider testing those patients early than you would otherwise. So I think it's really kind of being keen on the different symptoms, being keen on some of the surrounding demographics that kind of go hand in hand with this disease process. And when other things have been excluded and you still have a symptomatic patient, kind of start thinking outside the box rather than just giving up on a patient, thinking a little bit outside the box to some of these rarer disease processes. So
Jason, if you have a patient that you see, they're very tired all the time, they have no energy, they're very short of breath, they can hardly do anything. As a matter of fact, they're in their 70s or 80s, and you do the regular investigation, you do an EKG, it's looking pretty good, but no real sign of LVH. You do an echocardiogram, an ultrasound of the heart, and you find some hypertrophy or thickening of the heart muscle, but the heart function looks superb. I mean, the ejection fraction is like 45 to 55%, completely normal. So if you're short of breath and you have a normal pump, function, you have to think about amyloid in these patients, right?
Yes, that's absolutely correct. So one of the kind of red flags that we use in our office are, patients that have extreme symptoms, very short of breath, very dyspneic with exertion, very miserable. They've been hospitalized once or twice. They're just very miserable. But you look at their echo, you look at their echocardiogram, and it just doesn't look that bad, right? They've got a normal ejection fraction, maybe a little mild LVH, maybe a little TR, nothing for a cardiologist that would, really kind of make you worry about the echocardiogram. These are exactly the patients that would be reasonable to be tested. Some of the additional red flags, we talked about already, is the LVH on the echocardiogram, but let's say a normal or low voltage on EKG on the electrocardiogram. So this shows a discordance, right? You're seeing, a big LV on the echocardiogram, but low voltage. So this would be suggestive of some sort of infiltrative process, which is what the cardiac amyloid protein does, infiltrate the heart. Other things that would lead you in that direction are, blocks, various different blocks, heart blocks or the need for a pacemaker. Other things, other organ failure, such as kidney disease or polyneuropathy or dysautonomia, which is something that makes these patients very miserable. Another one is the bilateral carpal tunnel syndrome. That's a huge red flag for TTR amyloid, as well as biceps tendon rupture. That's another one. And of course, troponin levels and elevated BNP. So these patients don't look so bad on echo, but their troponin's elevated, which is a heart marker for potentially heart stress or heart damage. And an elevated BNP, a brain natriuretic peptide, was also another marker for ventricular or atrial stretch or volume overload. So looking at some of these red flags in the setting of a normal ejection fraction or echo can kind of give you confidence that maybe, looking for cardiac amyloid would be worthwhile.
Very much. Thanks, Jason. What you described reminds me a lot of my patients that are in their 70s or even in their 80s. They have, their blood pressure is very difficult to control because they go hypertensive, but when they stand up, the blood pressure really drops significantly, very, very labile. But then what about some of the younger patients? For example, I've had some patients, African-American, that were younger with an incredible amount of hypertrophy on their echo. As a matter of fact, some of them had an obstructive dynamic. I mean, we had to, even some of them, we send them to surgery to get a septectomy or removing part of the septum, part of the wall of the heart so they wouldn't have this obstruction. Does that kind of clue in more to the more familial type of amyloidosis in those cases rather than the wild type?
Yeah, that's an excellent question. Distinguishing between, cardiac amyloid and hypertrophic cardiomyopathy can be a little tricky because on echo, they even look the same. The symptoms, as a matter of fact, can be very similar. One of the telltale signs to decipher between cardiac amyloid and hypertrophic cardiomyopathy would be the EKG. As we all know, the Electrocardiogram, usually show the just massive, R waves, indicating the high voltage for the EKG on the cardiac or for the hypertrophic cardiomyopathy patients. Whereas in the infiltrative or amyloid patients, these voltages are very low. So it's actually a very quick and easy way to kind of lean you in one direction or the other, whether or not these African American patients, have a hypertrophic cardiomyopathy, or maybe this is just amyloid. Other things that you need to think about in young patients, as you suggested, is the hereditary type of amyloid. This is the abnormal transthyretin protein that's made in the liver. These patients develop cardiac amyloid earlier in life. So that is, a demographic, again, African American population. This particular abnormal gene is present in about 3.4% of African Americans. So this is something that needs to be thought about, needs to be considered in these patients, and can easily be identified with genetic testing. Just a cheek swab. Don't even have to do a blood test in a lot of cases to actually identify some of these abnormal genes, which can also identify people with hypertrophic cardiomyopathy as well. So all of these, diagnostic tests can be helpful in distinguishing, young African American patients with LVH on echo.
So we have the AL amyloidosis, which is one of the most common. I mean, the AL amyloidosis, the light chain, is it like multiple myeloma type of picture? Is that when we work with the oncologist, the hematologist, maybe to help us differentiate these patients versus the others?
Yes, correct. So all patients, if you're worrying or considering cardiac amyloid, the recommendation is to test for both TTR amyloid and AL amyloid concurrently or at the same time. So generally, what that would look like would be a technetium-labeled phosphate scan, which will look for the abnormal TTR protein in the heart. And at the same time, we check blood levels for free light chains, as well as serum and urine electroproteinophoresis. This will distinguish those patients that may have AL amyloid. So the free light chain, kappa and lambda free light chain studies will detect the plasma cell dyscrasia, the abnormal production, either the kappa or lambda light chains. And then, of course, the protein, serum, and the urine electrophoresis will tell you if it's a monoclonal spike, which would indicate a particular cell that's producing that abnormal protein in very high abnormal amounts. If those are positive, the recommendations are, if there is an M spike or monoclonal peak is what it's called, to get those patients evaluated by a hematologist or oncologist, because the possibility of having AL amyloid would be high. And the pyrophosphate scan would actually identify patients who may have TTR amyloid. So those are kind of the initial screening tools that we use to begin to dissect away, which amyloid a patient may or may not have.
I've been ordering these tests. For light chains, kappa and lambda light chain, and a lot of them are coming back abnormal. I'm not sure. Is there a certain level where you kind of get concerned about? Is there kind of a ratio we need to look at, or we should just, if you have an abnormal finding, you should refer them to the oncologist?
Yes. So what I've done, because we've got a very good multidisciplinary group that's willing to see patients, any sort of blood abnormality with the free light chains, which is a blood test, or with the protein electrophoresis, I will get them to the hematologist for evaluation. But generally speaking, to have multiple myeloma or AL amyloid, the free light chain ratio is very elevated, either high or low, depending on which free light chain you have. I think the normal ratio is between, I believe it's 0.5 and 1.5. So if you're either below that ratio or above that ratio, then that would be abnormal. And then in addition to that, having a monoclonal peak would be suggestive of having some sort of plasma cell dyscrasia, whether that's MGUS all the way to AL amyloid, would be something that would need further evaluation. So we are worked very hand in hand with our hematologists at our health center, because sometimes there is some questions and there is some overlap there. So having a good relationship with your hematologist, your local hematologist, is always important for a local, cardiac amyloid program.
So for the patient, I guess what we have to remember is that you're short of breath, you have normal pump function. First thing we do is we get a blood test. And if it's, the kappa and lambda light change that we measured, if abnormal, you're referred to a hematologist and try to sort it out. Now, you mentioned a technetium pyrophosphate that you could maybe detect changes in patients that had familial type. Now, would they show? First of all, I'd like for you to kind of explain a little bit more about that technetium pyrophosphate. For the patient's sake, what should they expect? Is it just an injection and they take pictures of it? Can you explain a little bit more about that scan?
Yes, so the technetium labeled, which is the radio tracer that we use, that's labeled to the pyrophosphate, which is the molecule that binds abnormal TTR cardiac amyloid protein, is really the scan of choice, and has become kind of the gold standard for, or not the gold standard, but the best non-invasive way of detecting TTR amyloid. So the sensitivity is about 99%, specificity is about 97%, so an excellent test. The gold standard is actually RV biopsy, so cardiac biopsy is truly the gold standard, but a non-invasive way of identifying cardiac TTR amyloid is always important. So the test itself is actually fairly straightforward. What a patient would expect is about a 3-hour test. So you show up usually in the morning and you are injected with the radio tracer. This is the technetium labeled pyrophosphate scan. There is a wait of about an hour while the radio tracer circulates through your blood and has time to bind to anything where the TTR may be, and specifically in the heart, if that's what we're concerned about. At the 1 hour mark, a scan is done. This can be done with a either SPEC, which is like a typical stress test that's done in a scanner, or it can be done planar, which is basically just a kind of a plain film, just a one-dimensional film, which is a little bit quicker and easier for patients. If the scan is positive, then you're done. Positive is read by the radiographic techs that look at a ratio, a preliminary ratio, and if it's positive, then there's no need to go any further. If it's kind of equivocal or not necessarily positive, they'll wait a few more hours. So they could potentially wait 3 hours and repeat the scan to see if there's any more uptake of this radio tracer in the heart. If that remains negative, then it's a negative test, which is very reassuring for not having cardiac TTR amyloid. But if the test is positive, this is a very good, sensitive, and specific test, and in most cases would lead to the diagnosis of cardiac TTR amyloid, and then would lead to potential therapies. Now, I will say that there is a small group of patients where the test is equivocal. No test is perfect, so you can have these gray area tests where it's not negative, but it's not truly positive. So what do you do after that? So there is a small group of patients that need to proceed on with cardiac biopsy or right ventricular biopsy. And this could be used as the tiebreaker, so to speak, to see if a patient, has cardiac TTR amyloid or not, or really any, infiltrative or restrictive cardiomyopathy. Sometimes the cardiac biopsy can be very helpful. So being at centers that have that capability can be, important when you're looking for a diagnosis.
So, Jason, let's say someone's test comes back positive, and based on your history, physical tests and scans, that you now say this person has a amyloid as a what's next to expect for a patient? What's the process?
Yep. So all of our positive scans, we see them in the office, and we at that point kind of do two things. Number one, we talk to the patient about their symptoms and about their diagnosis, and if it's very clear cut, then what we will do at that point is that has identified them as having cardiac TTR amyloid, but has not identified their type. So the next question that you have is this wild type, due to a normal protein, or is this hereditary due to a mutant protein? So all of our patients, one of the first things that we do is genetic testing. So genetic testing in our office is actually very easy. It's just a little cheek swab that we do. We actually are able to do this test for free. We've been kind of gifted being able to do the genetic testing for free. It's normally, a couple hundred to several $100s. So we're able to offer this to all patients to test their gene to see if they're wild type or hereditary. So that's one of the first most important things that we do at that visit. The second thing is getting them started on therapy. So if we are convinced that a patient does indeed have cardiac TTR amyloid, then the second thing that we do would be to begin the process of getting them on medications. The only approved medication at this time for cardiac TTR amyloid is a medicine called tafamidis. The brand name is also Vyndaqel or Vyndamax. So we start all of our patients on therapy as well. So those would be the two things to expect kind of on a standard follow-up patient that has a positive pyrophosphate scan. Now, as we talked about before, some patients can be equivocal or on the fence. So there's a smaller group of patients where we end up talking about that, and we talk about doing a heart biopsy or a right ventricular biopsy as a way to really identify if the patient has cardiac amyloid or not. These medications and the genetic testing, are additional parts and things that we don't want to do or start patients on if they don't absolutely need it, largely because of the cost of the medications. So for all of our patients, we really want to make sure that they do indeed have cardiac TTR amyloid before starting therapy.
Thank you, Jason. I remember going back on the technetium pyrophosphate. I remember in the 80s, we used to order this test to detect myocardial infarction. So it's been around for a long time, and it's nice at least to have a tool like this that can really identify the problem in some of these patients. When do you test with a cardiac MRI, or do you ever?
So cardiac MRI is good. And you have varying opinions on the utility of cardiac MRI. So cardiac MRI will tell you if there's abnormal findings in the heart, but of course, so very sensitive, but not necessarily specific. So there are, a handful of different infiltrative cardiomyopathy processes that can have a similar pattern to amyloid. So with cardiac MRI, you look at patterns, and these patterns are either diagnostic or non-diagnostic, but it doesn't tell you for sure what you have inside your heart. It just suggests that you have scarring or, infiltrative processes type going on. So at our center, we use cardiac MRI. Sometimes it's a tiebreaker. If someone has an equivocal pyrophosphate scan, we're looking for something else to add to that, and someone doesn't want to have a biopsy, then sometimes we'll do cardiac MRI. But to be honest, with the success and the high sensitivity and specificity of the pyrophosphate scan, and then the very few folks where it's non-diagnostic or equivocal, and then moving on to biopsy, really the utility, and this is our center, you would have people that would argue otherwise, probably people that are heavily invested in cardiac MRI or imaging that would probably argue that everyone should have a cardiac MRI, but we just haven't found it necessarily helpful in the long run. Mainly because it still doesn't give you an actual diagnosis. It's still just a pattern on an imaging modality.
Well, let's talk about the treatment maybe a little bit more. We have obviously we can have a candidate that is a patient that is young, has this very severe increase in thickness of the heart muscle, this severe cardiomyopathy. At the other spectrum, we have our 70 or 80-year-old that may have a wild type of amyloidosis. Some of these patients actually may have had a problem with their aortic valve. We know that, for example, about 20 to 25% of our patients in their 80s, they've had a TAVR or they've had problem with their valve. And Dr. Ahmed, treats a lot of these patients. Do you treat all these patients the same way? And if you treat it with this medication, how long do you treat them for?
Yeah, those are all great questions. So this comes down again to the distinguishing between the wild type TTR amyloid and the hereditary TTR amyloid. So 2018 was a great year for cardiac amyloid or TTR amyloid in general. There was actually 3 medications that had positive effects for patients with TTR amyloid. The first one was tafamidis. That was the ATTRACT trial, which was hugely successful, published September 2018 in New England Journal of Medicine. and was approved for all types of cardiac TTR amyloid. So cardiac amyloid. So it was the first and only. Now, the other two medications came out a little bit earlier that year, 2018, in July, New England Journal of Medicine. And they looked specifically at the hereditary type, or the mutant type of TTR amyloid. And they did not look at the cardiac manifestations. They actually looked at the neurologic manifestations. So these two medications, one is called patisiran, or Onpattro is the brand name. The other one is inotersen, or Tegsedi is the brand name. Were both approved recently, about a year ago, for polyneuropathy associated with hereditary TTR. So the first thing when we see patients and they have cardiac TTR amyloid, we start them on tafamidis because that is the only medication. This medication, as I said in the ATTRACT trial, was shown to improve symptoms at 6 months. So we tell patients to expect an improvement in symptoms at about 3 to 6 month range, which we've actually found to be true. And a mortality benefit at 18 months. So that'd be a year and a half. The curves for mortality begin to separate pretty significantly. So we tell patients to expect to be on this medication lifelong. This is a lifelong process of the abnormal protein being generated out of the liver, and with the very low side effect profile of the medication. As a matter of fact, the same as placebo, so virtually no side effects. And the chronicity of disease, this is a medication that people stay on lifelong. Now, tafamidis does have the dubious distinction of being the most expensive cardiovascular drug on the market. It has a list price of about $225,000 a year. So it is a very expensive medication. And this actually pales in comparison to patisiran, which is $350,000 a year, and then inotersen, which is $450,000 a year. So this is a rare disease space. So that we are, in our office and clinic is used to the rare disease space, specifically with pulmonary hypertension. So pulmonary hypertension, like TTR amyloid, is a rare disease. So their medications are hundreds of thousands of dollars a year. So it takes kind of specialty office staff to be able to work through that process to get these medicines approved, to go through specialty pharmacy to get the medicines delivered. And in some cases with patisiran and inotersen, going through infusion clinics to get the medicines for the patients. As you might imagine, being a healthcare provider, I take all these medications very seriously. I take our healthcare dollars very seriously. So being able to identify patients, with very high certainty before going down the pathway of medications is important. The short answer to your question is, these medicines are lifelong because these disease processes are, constantly ongoing. And because of the benefits of the medications, it's hard to deny them to patients. And we work the best that we can to get them affordable for the patients, including being involved in clinical trials. So we're lucky to be invited to be part of the ATTRibute trial, which is looking at AG10, which is an investigational small molecule that stabilizes TTR. So kind of a tafamidis competitor, if you will, by Eidos Therapeutics. So we are actively enrolling in this trial, and we've been able to use patients who couldn't afford tafamidis to be able to get them in this clinical trial to potentially get them a therapeutic agent, obviously to help them in the meantime. So, cardiac amyloid is an exciting field. We now have therapies, we now have treatments, but just like with a lot of things, there's still, little speed bumps that need to be kind of worked through along the way.
So, Jason, just for an understanding of the advancement in treatment, what's the prognosis for someone today that has amyloid that is treated compared to the prognosis a few years ago? Are these incredible treatments that are curing people, or are these just progressing delay? That's the first question. The next question is, I was going to ask you about the role for transplantation and younger patients. Maybe there isn't one, but what's the current thinking on those kind of things?
Yeah, those are great questions. So the disease course, so the median survival, and this is what we tell patients, the median survival after diagnosis without treatment for your hereditary, TTR cardiomyopathy patients is about 2.5 years, right? So not great. And then the median survival after diagnosis without treatment for your wild type patients is about 3.5 years. So the hereditary, as you might imagine, with the abnormal protein, their survival is a little bit lower. A lot of the reason why, it says the median survival after diagnosis, right? So these patients have usually struggled with symptoms for, many if not several years before actual diagnosis, kind of similar to pulmonary hypertension patients where the mean time to diagnose is about 4 years. So hopefully with advancements and awareness, we can identify patients sooner, which means that their median survival will be longer, but the data is what it is. And you can just average the two, and basically your median survival is about 3 years. So this is a serious disease process, something that we tell all of our patients that we take seriously. And now with truly disease-modifying medications, the mortality can improve. And particularly for the ATTRACT trial, the reduction in all-cause mortality was about a 13.4% absolute difference in mortality, which is just a number needed to treat of 7.5 to prevent one death after 2.5 years. And in the cardiology world, the number needed to treat of 7 is actually quite good. Despite its expense, you can, really change the trajectory of this disease process. And of course, that's just at 2.5 years. If you imagine that these curves continue to separate, hopefully you could either double or even triple the life expectancy of some of these patients. Now, of course, other things that's added to that be the age of the patient, right? It's hard to make an 85-year-old live to 95. In this day and age, 85 has already kind of beat the odds, so to speak. So it all comes down to, kind of how sick or not sick the patient is at the time of diagnosis, and of course their age, because it's possible some other process such as cancer or something else could, take the life of the patient before the amyloid would. But those are generally kind of some of the rough estimations that we give for mortality for the patients.
Jason, how do you follow these patients in the office? Is there a difference in the technetium pyrophosphate scan, for example, with treatment? Let's say 6 months to a year, do you see actually a normalization of that scan, either by technetium pyrophosphate or CMR?
So that is an excellent question. So now we're getting into some of the kind of exciting things in the field. So now that we have a therapy, which was FDA approved just in May of last year, so we have exactly a year's worth of approval on the medicine. So we can now begin to start answering some of those questions, right? So as patients improve, can we see that improvement? Can we detect that improvement on echo? Can we detect that improvement on cardiac MRI? Maybe there's some utility in showing progression or regression of the disease process with cardiac MRI. Same thing with the technetium pyrophosphate scan. So these are all excellent questions and unknown at this time. We are kind of doing our own, single center study, repeating some of these exams a year after a patient has been starting on therapy, and seeing if there is any quantifiable change either with echo or pyrophosphate scan or cardiac MRI if we had that before the patient started therapy. So these are all excellent questions, and we hope in the next few years, as we have more patients on therapy, we begin to kind of see if there is actual true regression, which I believe that there will be, of this disease process. So again, emphasizing kind of the disease modifying aspect of these medications.
Do you work with the transplant program? Do you actually perform sometimes liver transplant, since the familial type, will have just abnormal protein just coming out of the liver?
Yep. So transplant has been a hot topic in this disease process. So we can kind of take a little step to the side and talk about AL amyloid. So cardiac AL amyloid, there is some data for transplanting these patients, some positive data, in fact. I think before people used to shy away from transplants in these patients, but there have been several groups that have shown good outcomes, the same as patients with any other cardiomyopathic process. Patients with TTR amyloid, this becomes a little bit different. As you know, the wild type form of TTR amyloid is generally in older patients. Usually a cutoff for age for heart transplantation is about 65 years old. Most patients with wild type TTR amyloid are generally older than 70. But it's not true for the hereditary type. So patients with hereditary type TTR amyloid, one of the transplant options for them is a heart liver. So actually, when I was training at a UAB, where you guys in Birmingham, where you guys are at, we actually did the first heart liver transplant for a young hereditary TTR patient, and he did very well. So those are some options for the younger hereditary type. Where you do the heart, that has been damaged from the abnormal protein. And then, of course, the liver is exchanged for a new liver that doesn't make that abnormal protein. So those are both options, transplant options for patients with cardiac amyloid.
Thank you very much. So if you're a patient that is very short of breath, and if you're fatigued, tired, low energy, your pump function is normal, you have to think about amyloidosis. Now we have some very interesting treatment. If you're that patient, let's discuss with the doctor, with the physician, because it's really, there was no treatment before, so a lot of times it was almost academic. But now we have something that can make a difference for this patient's life. So
yes, particularly if you've had that recurrent hospitalizations, you go into hospital, heart failure, get treated, go out, go into hospital, get heart failure, get treated, and people are like, that's much worse than we would have expected in the day and age of getting another opinion. I think this shows the importance of having a strong heart failure program and a heart failure section that's kind of leading the charge on this.
Yeah, and I absolutely believe that the multidisciplinary aspect of this disease process is important. So neurologists, they see these patients with polyneuropathy, and orthopedic surgeons see these patients with bilateral carpal tunnel syndrome, and hematologists, see these patients as well. So, talking to our friends and colleagues in a multidisciplinary way in order to share these patients and get these patients to the right person is always important. We also have an excellent relationship with our interventional cardiologists that do all of our TAVRs. As you know, depending on what data set you're looking at, the prevalence of TTR amyloid in those patients is anywhere from 5 to 25%, especially in your kind of paradoxical, low flow, low gradient, severe AS patients. So we've teamed up with our structural heart group and have actually now begun routinely screening all of our TAVR patients at the time of discharge after their TAVR, just to make it easy for them to try to identify some of these patients and be able to get them treated. So again, multidisciplinary is always good, and being able to identify patients to get them feeling better, is good for everybody.
I do have one question, actually, just to get back to the clinical part of this. Jason, what comes first in clinical exam? Is it the carpal tunnel, the neuropathy, the heart failure, the liver? Like, what's the timeline? Because it sounds to me from everything you're saying that the earlier you catch this, the better. The earlier you can start treatment and diagnosis, the better. What's the symptom, timeline?
Yeah, no, that's an excellent question. So, generally, it takes a few years before these patients get identified. So what is believed to be one of the first symptoms is actually the carpal tunnel syndrome. So carpal tunnel syndrome, erectile dysfunction, polyneuropathy. So it's really the nerve kind of issues usually precede the diagnosis by about anywhere from 3 to 4 years. It's not until you get within a year of diagnosis when you start having the shortness of breath, orthostasis, pacemaker placement, EKG with low voltage, LVH, those all start getting within the year of diagnosis. So it's really kind of and it also depends on, the hereditary types are a little bit different, but generally speaking, it's usually the nerve aspect of things that really precede the diagnosis. And it's not until they start getting some of the cardiac manifestations when people really start trying to, identify what's going on with patients.
So is there ongoing trials, upcoming trials, maybe looking at those people that have not got cardiac manifestations yet or strong ones to see if it can be prevented?
That's a good question. So to my knowledge, there isn't. Prevention is always a tough pill to swallow, no pun intended, when that pill costs, $250,000 a year. So I think for a lot of us, in this field, trying to be good healthcare stewards, good stewards of money, we generally won't start therapy on patients, at least if it's approved for cardiac TTR amyloid. Now, if they have the peripheral neuropathy, they can get on some of the other medicines, the Tegsedi or Onpattro. But from a cardiac standpoint, if they are truly NYHA class 1 symptoms, meaning no symptoms at all, we just monitor those patients very closely. But as soon as they develop heart failure symptoms, then yes, we would offer treatment and get these patients on treatment. And, the clinical trials would bear that, they only recruited or enrolled people with NYHA class 2 to 3 to 4 symptoms. So no asymptomatic, patients were enrolled in any of the cardiac TTR trials.
Stresses the point that we shouldn't practice medicine in a silo. The heart team just getting larger and larger, but so important to take care of that patient, working closely with the oncologist as well as a neurologist and nephrologist. Thank you very much, Jason Guichard, Dr. Ahmed. Appreciate again your help, and we hope that you enjoyed this podcast.
Thank you very much.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.